Good evening and welcome to What Clinicians Want to Know, addressing current questions and controversies in the management of metastatic breast cancer. Due to unforeseen circumstances, although he's very well, Dr. Love will not be attending ASCO this year in person. So I'm Hope Rugo, a breast medical oncologist from the University of California, San Francisco, and I am filling in to moderate these very big shoes to moderate the evening tonight. So thank you all for attending. This is our faculty for today, and I will just introduce them as we go down, starting at the far end. Dr. Aditya Bardia, who's professor of medicine and now at UCLA and directs the breast cancer program, and assistant chief of translational research and director of translational research integration. And then we have Joyce O'Shaughnessy, who's a celebrating women chair in breast cancer research at Baylor University and chair of the Breast Disease Committee at Sarah Cannon Research Institute. We then have Giuseppe Curigliano, who's clinical director of the Division of Early Drug Development for Innovative Therapy and co-chair of the Experimental Cancer Therapeutics Program at the University of Milano and the European Institute of Oncology. Then Harold Burstein, who I'm sure everybody knows here, who's institute physician at Dana-Farber Cancer Institute and professor of medicine at Harvard Medical School. And then last but not least, Sara A Hurvitz, who's a professor and senior vice president in the clinical research division at Fred Hutch Cancer Center and head of the division of HemOnc at UW-Medicine. So Aditya recently moved to LA, and Sarah, not quite as recently, moved to Seattle. So we have a great group today. So these are the disclosures for the faculty. I'll just march through them here, although my mouse is not working very well, and Dr. Love's disclosures. So in terms of our commercial support, the activity is supported by educational grants from AZ, Daiichi Sankyo, Lilly, Merck, and Stenline Therapeutics. And then there are the planners for this group don't have any conflicts of interest. So this educational activity will include discussion of non-FDA approved agents and regimens. Of course, as we always discuss, you can refer to the official prescribing information for each product for approved indications. So Research to Practice hosted 9 live meetings associated with ASCO 24. This evening's program is the 8th. The final event is available virtually tomorrow, bispecific antibodies for lymphoma. One of the things that Neil has done, and I think everybody here who's ever been to a program from Research to Practice is aware of that, is to try and make the program as relevant as possible to participants. So there's a working group that Neil convened of 10 general medical oncologists, and then Neil interviews them virtually, and they posed cases and questions on a number of key clinical issues. So what are the key clinical issues facing you in practice? We'll feature video excerpts from each of these interviews during the program, and then have some questions for our faculty as we go through that. So we'll see. So where we're headed this evening is, here's the agenda. We're going to talk about HER2-positive metastatic breast cancer with Dr. Hurvitz, and then Dr. Burstein will talk about selection of upfront therapy for patients with HR-positive, HER2-negative metastatic disease. I will talk about what happens after CDK4/6 inhibitors when you're still using endocrine therapy for HR-positive disease. And then Professor Curigliano will talk about the future role of HER2-targeted therapy for HER2-low and ultra-low disease, as well as what we're doing today and after the data from this meeting. Joyce O'Shaughnessy will talk about selection and sequencing of therapy for patients with metastatic TNBC. And then last but not least, we'll talk about current and future strategies of patients with endocrine-refractory HR-positive metastatic breast cancer with Aditya Bardia. So let's start with our first module. The first thing we're going to do is start with a video, and Dr. Gigi Chen from Pleasant Hill, California, is going to talk to us about brain metastases in a patient with HER2-positive breast cancer. Let's hear what she has to say.
Good evening, everyone. I'm Neil Love from Research to Practice, This year participating in ASCO virtually. Over the last few weeks, I met with 10 general medical oncologists for individual hour-long Zoom recording sessions to chat with them about what they would like to see the faculty discuss at this meeting, including cases from their practice and specific questions regarding common clinical scenarios in their practices. To begin, we hear about one of the most common questions discussed over the last few years in metastatic HER2-positive breast cancer. The patient who initially is treated with THP, followed by HP maintenance for metastatic disease in the first-line setting, who has disease controlled systemically, but breaks through with clinical CNS disease. Dr. Gigi Chen has such a case.
She developed a brain metastasis that's in the right temporal region. She underwent craniotomy and resection and then underwent SRS. So in terms of the systemic treatment, what will be the best treatment at this time? Should we be continuing with her current treatment now that her brain metastasis is treated? Or, would the faculty change to a different HER2-directed therapy? Whether one would pick trastuzumab deruxtecan, given the new data in terms of the CNS penetration versus tucatinib, capecitabine, as well as trastuzumab.
So here we have a patient, and this is a patient we see all the time. They could have disease controlled systemically and really not have anything that's visible, who's received a Cleopatra-like induction and are on trastuzumab, pertuzumab maintenance. They develop an isolated brain metastasis. And I think the real question now is how to manage this patient. You've taken out the brain metastasis, you've done stereotactic radiosurgery. Do you continue the HP or do you change treatment? So Hal, how would you approach this patient?
It's unfortunately an all too common problem, and there really aren't any concrete data to guide. A lot of it really depends on how well the extracranial metastatic disease is controlled, and it sounds like in the case presented that things are actually very quiescent in the rest of the body. So given that she's already had focal treatment of the isolated brain lesion, I might be tempted to simply continue the trastuzumab-pertuzumab regimen, though, again, it's a data-free zone, and so in patients who have multiple lesions or who might get therapy systemically in a switch before getting definitive local treatment, which is how we actually approach a lot of these folks these days, I would probably switch to trastuzumab deruxtecan or to the tucatinib regimen. There is a growing literature that TDXD is quite effective in the brain. There was an abstract at the meeting here on that was a prospective study looking at that from Sarah Salmons at our group and others. So probably would think about switching if there was still residual or measurable disease in the CNS. If everything is clean, you might just wait and see what happens.
And Joyce, do you agree? Is that what you would do?
I definitely agree with what Hal was saying. It really depends what the systemic disease is doing, and also the natural history. How quickly did this brain met come on? I have a patient, a young Latinx woman who had like a solitary liver met, and with THP she went into a CR, and then unfortunately she was on maintenance HP, ER negative, and then about 18 months later, came in seizing with a sizable lesion, solitary, resected, SRS. What do? Keep the and I changed to the HER2 Climb regimen. The data showing that it can kind of prevent the recurrence, or it can prevent new brain metastasis, was what intrigued me, because I decided that her CNS was going to be her most aggressive side of disease, and that was going to be her problem. So I didn't want to keep her on the HP.
So, Sarah, if you saw a patient who's now progressed not just in the brain, but also, and has multiple brain mets, but also systemically, what's your first choice there? This is a patient who's progressed after a year or so, doesn't have disease that's very sensitive to HP.
Yeah, in that situation where there's systemic disease that you're worried about as well, I think TDXD tends to be my go-to because of the very compelling objective response rates, progression-free survival. The data that we lack is looking at TDXD versus tucatinib, capecitabine, trastuzumab. You can look at the individual trials. It's not fair to cross-compare, but I do think TDXD's data has been pretty compelling. And if you look at the mounting literature literature supporting TDXD and brain mets. Some came out at ESMO Breast recently. We have the Destiny Breast 12, we have Tuxedo and Deborah. It does appear to be pretty active in the brain, and so I would feel comfortable in that situation.
So you would be driven to change to TDXD also because there was systemic progression?
Yes.
And Giuseppe, I'm not sure that everything is available in the same setting in Italy, but can you use either one?
No, we can use for sure trastuzumab deruxtecan for a patient progressing to THP. So specifically for a patient like this, trastuzumab deruxtecan will be my first option. You have a very high response rate. The disease control rate is close to 90%. You can achieve also response on brain mets. I would also like to say that if you have asymptomatic brain mets, you can also delay radiation therapy and start first with trastuzumab deruxtecan. Sometimes you may have response.
And we'll talk a little bit more about it, but do you choose to use TDXD generally in the second line as opposed to the HER2 Climb regimen, Aditya?
In general, yes. Given the magnitude of benefit we've seen with TDXD, and at ASCO this year, we also saw finally the median overall survival, and it looks, very impressive. So in general, my preference is to use TDXD.
That's great. Well, we have another video now to talk about TDXD itself and quality of life and how to manage low-grade ILD.
With the recent pan-tumor approval of TDXD, the number of questions from oncologists in the community about this fascinating therapy has multiplied exponentially, including and in particular the prevention and management of toxicity, and of course the key issue being interstitial lung disease.
The patients that I see treated with trastuzumab deruxtecan, I personally see a pretty wide range of tolerability, where some have, a pretty reasonable tolerance, and other people are majorly impacted with fatigue, nausea, hair loss. In terms of quality of life, I'd love to hear from the faculty what their experience is, and how they, especially with trastuzumab deruxtecan, what strategies are employed to maintain people's quality of life when receiving treatment in the metastatic setting with these newer agents. Now we're several years in with our clinical experience on TDXD, and I would say, at least personally, I continue to struggle with the optimal strategy to diagnose and manage ILD for these patients, because we often pick up on essentially a grade 1 and asymptomatic, ground glass opacity on their scan, and, have to then go through the treatment protocol to manage this. So I'd love to hear from the faculty the experience that you've had, as well as any really helpful diagnostic tools or protocols you follow for detecting and managing potential ILD. I would say especially grade 1 is sometimes a challenge. When they're symptomatic, it's really clear to know what to do, but this persistent grade 1 that we encounter, frequently when we're treating our patients.
And I think that we all deal with this a lot. I'm really interested in how everybody looks for ILD. How do you monitor and detect ILD? Joyce, what do you use in your practice?
I do non-contrast chest CT scans every 9 weeks. And exactly, Layla's correct. We have a GERD, we have postnasal drip, we have all these things that can mimic a grade 1 asymptomatic ILD. But when we see anything that could be ILD in the context of TDXD, we have to stop. We have to treat with steroids. Of course, I'm going to treat the GERD, and I'm going to treat the postnasal drip as well. And when it resolves, really resolves, then we can reinstitute TDXD. And in a recent summary that Hope put together at ESMO Breast, people that waited for complete resolution of the grade 1, this is in a kind of a pan, lots of trials with TDXD, waited for complete resolution, and then we resumed it. And particularly, you correct me, what I took away, people who reduced the dose. I always reduce the dose one dose level. I don't want it back again, basically. They did fairly well. There were some recurrences, but I think they cheated a little bit and didn't wait for it to completely resolve. So we have to be rigorous, because the thing is, otherwise, the women will lose the opportunity to benefit from this really great therapy.
Actually, only a few people dose reduced, but some did. And there were repeated cases of ILD in a few number of patients. Nobody came close to dying of it, and people stayed on for a very long duration, so it can be of great benefit. Hal, do you give steroids usually for grade 1 ILD?
So you're the expert here, so I'm going to defer to you on whether to give steroids, because I know you just gave such an important paper at ESMO Breast. I would just echo what Dr. Agarwal said in that video, which is this is obviously an important drug. It's going to be our first-line drug for HER2-positive metastatic disease, and increasingly we're using it in non-HER2-positive disease, and I'm sure Giuseppe will update us on that later on. But it does have these side effects, and fatigue actually is more of a problem in my clinical management on a day-to-day basis than ILD. And I don't have a good answer for that. I mean, I encourage patients to do low-grade exercise or other things, but it's an issue with this drug, and I hope that we get a little better. In terms of what I do for what would be asymptomatic, ground glass opacities, other changes, I usually just hold the drug, wait a couple cycles, and see if it gets better. And I typically reserve steroids for more extensive disease or symptoms, but you'll tell us what the right thing is here.
I'm a big steroid user, but I don't want to wait too long, so I just start the steroids, rescan in 3 weeks, and restart, Okay. So, but I think that's, and in fact, in our pooled analysis of 9 studies, we found that a lot of patients had received steroids, so, and that seemed to be part of the retreatment strategy for people. And Sara, we don't see a lot of cytopenias, but we do see nausea that can be longer lasting, and some patients have alopecia. How do you approach those different toxicities?
Yeah, I think ASCO a few years ago put out the updated guidelines for antiemetic use based on how high the emetogenic risk is of an agent. And I use the highly emetogenic agents risk sort of recommendations, which is incorporating everything you can, the NK1, the 5-HT, having patients, telling patients up front, let me know if you're in trouble. Olanzapine, I tend to use a lot of. And one thing I'm careful of is patients I've seen lose weight, and you have to remember to redose them if they lose more than 10%, because you're overdosing them, and then they get sicker again. So I had a patient who was doing okay, but then she lost some weight, and we were doing too much. So keeping your eye on the ball and making sure that you're using very aggressive antiemetics up front.
And what would lead you to dose reduce?
If they were losing weight, vomiting, and it was resistant to this therapy, I think dose reduction is important. I dose reduce not infrequently for nausea, I must say. A lot of patients are on this therapy a long time, and we want them to have a reasonable quality of life.
Yeah. That's a good point. So let's hear about CDK4/6 inhibitors and HER2-targeted therapy in this next video.
Of great interest to general medical oncologists in practice about patients with HER2-positive metastatic breast cancer is the patient with triple-positive disease and the role of endocrine therapy in these patients, as exemplified by a case from Dr. Sachi Gupta, who initially treated a patient with THP therapy, which the patient responded to but tolerated very poorly. On progression, the patient sought a second opinion and came back to Dr. Gupta, who was surprised at the opinion, but yet implemented the regimen.
We switched her to CDK4/6 inhibitor in combination with trastuzumab and aromatase inhibitor. And now her quality of life is amazing, and the disease is still stable, but, she's doing better than she was on chemotherapy. This is not something that we do regularly on a day-to-day basis. I was quite concerned about using this combination, but, she had instructions from the second opinion, so I went along with it, and she's handled the therapy really well so far.
Any questions for the faculty?
Yeah, is there any data regarding use of CDK4/6 inhibitors in combination with HER2-directed therapy for ER-positive and HER2-positive cancers?
We actually saw some data here at this meeting about this very topic, and we're waiting for some other information. Aditya, how do you approach the use of endocrine therapy in this setting?
This is a different scenario in terms of what this patient received, but in general, for a patient with ER-positive, HER2-positive metastatic breast cancer, when they're on maintenance HP, that's the time I use endocrine therapy, and if they have disease progression, usually my second line is TDXD. and generally I do not use endocrine therapy with TDXD. Having said that, as far as CDK4/6 inhibitors are concerned, we have data from 2 trials now. The first was the Monarch-Her and now Patricia, both of them showing that the addition of CDK4/6 inhibitor to trastuzumab with an endocrine therapy is a strategy that could be efficacious. And in the Monarch-Her, you saw that it was even better than chemotherapy. So I guess this patient had a lot of side effects, and that's why the physician wanted to use a regimen that would have low side effects and is doing well. So it's reasonable, but I would generally have done TDXD and then after that consider other therapies.
So when would you use a CDK4/6 inhibitor with HER2-directed therapy? At any time in the first-line setting or as maintenance?
In the first-line setting, CDK4/6, not yet till we have additional data, but definitely in the later-line settings, we do have patients who've used THP and then TDXD and tucatinib, and you're looking for additional options. And at that time, it's very reasonable to consider a CDK4/6 inhibitor. Monarch-Her was with fulvestrant, but biologically AI could be used, which can be easier because fulvestrant is every 4 weeks and trastuzumab is every 3 weeks, which can be very problematic in terms of number of times a patient has to come in. But with the use of AI, it just makes the scheduling easier.
Yes, I have a patient who's, I think, 15 years into her metastatic treatment, or 18 years, and she's been on abema and fulvestrant with trastuzumab now for 3 years, so it can work. So we're going to hear from Sara about optimizing the management of HER2-positive metastatic breast cancer.
Thank you so much. What I'm going to do is just review sort of the standard of care for second line and beyond now. The first line, of course, hasn't changed now in 12 years, standard being THP. But in the second line setting, after patients have seen trastuzumab and taxane, we now have this molecule on the left here. You're all aware of TDXD, high DAR, tumor selective, cleavable linker, and bystander effect of the payload, allowing killing of tumor cells with lower expression of HER2. And these features favor its efficacy both preclinically and then clinically compared to TDM1. From the DESTINY-Breast03 clinical trial, this was a study done of TDXD head-to-head against TDM1, which was the standard of care in the second-line setting after trastuzumab and taxane. This study led to the approval of TDXD in the second-line setting. Shown here is the progression-free survival curve. Early separation of the curves, a 4 times greater median progression-free survival with TDXD versus TDM1. TDXD, median PFS, 28.8 months. If you think of the Cleopatra median PFS in a patient population who 90% of whom were naive to trastuzumab, that median PFS was 18.7 months. So many of us think these data indicate that the first-line study of TDXD versus THP will likely be positive, but we don't know yet. This is showing those data compared to the other second-line data that we have after trastuzumab and taxane, showing just how much better TDXD is in this setting. And the overall survival, very importantly, was statistically significantly greater. This was just updated and published and presented with the final overall survival showing a highly significant benefit with TDXD, solidly placing it in the second line setting. And again, the waterfall plots, go without saying. The responses that we're seeing are just phenomenal when you look at TDXD. Now, we also have been talking about tucatinib, which is a HER2-selective tyrosine kinase inhibitor meant to mitigate the side effects owing to the EGFR inhibition, so hopefully less diarrhea and skin toxicity. Also, early evidence of blood-brain barrier penetration, leading to the evaluation of this drug in patients with active brain metastases or a history of brain metastases. Well, in the second-line setting, a regimen with tucatinib was studied and presented at San Antonio, the HER2CLIMB-02 study, which was designed and done before TDXD became the standard of care second-line regimen. So this was using the TDM1 standard of care after trastuzumab taxane and adding tucatinib to it or placebo to it. And in this study, 44% of patients had brain metastases. Nearly almost all of them had received pertuzumab, so it was a modern regimen received by patients prior to going on this study, but nobody had received TDXD. So these data that I'm going to show you do not address how well this regimen works post-TDXD. The progression-free survival was significantly improved with tucatinib added to TDM1. This triggered an overall survival analysis that was very immature. There were only 53% of events, and there was no significant difference between the two arms at this early look. And shown here, again, cross-trial comparisons are dangerous, but it is still, we all think of them. So I've put it in sort of this graphic to show you how TDM1 tucatinib compares to TDXD because they were fairly similar patient populations. And I think this sort of, there was toxicity with the TDM1 tucatinib regimen. There was LFT elevations, grade 3 or greater in 16% of patients. This regimen is not yet available, so for me, TDXD remains the standard of care after trastuzumab taxane. And then, as Bill Gradishar would say, entering the wild, wild west of the third-line setting and beyond. Most of these studies were done after TDM1. The DESTINY-Breast02 looked at TDXD compared to either trastuzumab or lapatinib in combination with capecitabine in patients who had already had TDM1. So most of these were later line patients. And again, you can see the progression-free survival was significantly better, much better with TDXD, and overall survival was much better. Also done in this setting was the HER2CLIMB trial. This led to the original approval of tucatinib. This was a third-line setting and beyond of tucatinib tras-cape versus tras-cape. Again, nearly 50% of patients had brain mets. The PFS and overall survival was better with tucatinib, capecitabine, trastuzumab. And that leads us to a very short discussion on those patients with brain mets, as we've been talking about, because brain metastases are a very significant problem in our patients with HER2-positive breast cancer. Lots of data has shown up to 50% of patients with HER2-positive metastatic disease will experience brain metastases. These data here came from over 16,000 patients looking at the prevalence of brain mets based on line of therapy and based on whether patients had co-expression of hormone receptors. And you can see for our patients who have hormone receptor negative HER2-positive breast cancer, by the fourth-line setting, 37% of them will have brain metastases. So this begs the question, should we be looking at patients proactively for brain mets who are asymptomatic, or do we only scan them when they have symptoms, now that we have targeted therapies that may impact intracranial responses, like these data from HER2CLIMB showing that there's an overall survival benefit by using tucatinib in those patients with brain mets, and nearly 50% of patients will have an intracranial response with adding tucatinib to capecitabine and trastuzumab. We also have evidence that ADCs, which are bulky molecules, and we never thought they could cross the blood-brain barrier, can benefit patients with brain mets. And we're seeing intracranial responses with TDM1, 20 to 30%, depending on the trial. And even with TDXD in the DESTINY-Breast03, you can see those patients, 82 of them in this trial who had brain mets at baseline, which had to be stable and not symptomatic, were deriving benefit with TDXD. In the DESTINY-Breast02, similarly, those patients with brain mets were deriving benefit. Intracranial objective response rate was over 60% with TDXD, which compared favorably to TDM1. So this drug does appear appear to be very active. There was a pooled analysis of all the Destiny breast trials in brain metastases showing that patient outcomes are better with getting TDXD compared to the comparator arms in these studies. And we have prospective and registrational studies showing these kinds of waterfall plots intracranially with the use of TDXD. So the Destiny Breast 12 study is prospectively interrogating the activity of TDXD in active brain metastases. And again, HER2CLIMB-02 also shows benefit with a progression-free survival in those patients with brain metastases. In fact, based on the forest plot, most of the benefit by adding tucatinib to TDM1 may be in those patients with brain mets. We haven't seen all the data from this study yet. And so with that, I'll pass it back.
Thanks very much. That was great. Really fabulous overview. We're going to move on to Module 2 and talk about our selection of upfront therapy in patients who have HR-positive, HER2-negative disease. So we're going to take a little bit of a step in a different direction now. And we're going to hear of some from the faculty, the grouped faculty in interviews. And Neil will tell us a little bit more about this.
With the approval and extensive documentation of benefit from 3 CDK inhibitors in the metastatic setting, it's been interesting to observe the back and forth about selection of these agents over the years, first based on symptoms and now more recently because of overall survival, as demonstrated by a case from Dr. Agarwal.
I have a patient who's 72 years old. We started treatment with endocrine therapy with an aromatase inhibitor and ribociclib. However, this patient unfortunately developed transaminitis that required dose holds. It was recurrent. We did dose reductions, recurred again, over and over again until finally on the lowest dose, she continued to have transaminitis requiring dose holds.
I was kind of surprised how hard you tried to keep the ribo going.
Mm-hmm. Yeah. And I guess that's another question, how soon would you discontinue or switch, or do you really try to dose reduce to the lowest possible dose before trying to switch to a different CDK4/6 inhibitor?
We all are well aware of data on ribociclib and overall survival. Question is, in elderly patients, it does become a significant issue of tolerability. And many of them have significant cardiac problems. Patients don't tolerate it well. I know the overall survival, but quality of life supersedes overall survival in that case. And I usually go with palbociclib. And question is that what faculty would advise too? And I have good luck. Many patients living for 4 or 5 years. And then 8 is when they live 4 or 5 years of good quality of life. They are extremely happy. I don't care overall survival significantly increased or not. It's a quality of life more important. So I want to know what faculty thinks about that, in particularly elderly group. If it is 50-year-old, 55-year-old, everybody will go with ribociclib. So that's just the issue.
So, Giuseppe, if you have a patient who's having problems with the CDK4/6 inhibitor in the metastatic setting, do you first do aggressive dose holds and reductions, or are you more inclined to switch? And rather than cytopenias, because often you can manage those with dose holds, what about when you have, for example, hepatic enzyme elevations or bad diarrhea?
I had many patients with transaminitis specifically. I dose reduced, let's say to 400 milligram, then to 200 milligram, but if still persists liver toxicity, usually I switch to another CDK4/6 inhibitor. We can do this, so I believe that I am perfectly in agreement with Dr. Gupta. Quality of life is quite important, so coming back every time, if there is still toxicity, the best thing to do is to switch to another CDK4/6 inhibitor. I did, and the patient was more comfortable.
Just one follow-on question. How long would you wait for the liver enzymes to improve? Because it can be quite lengthy.
Yes, usually I wait at least 10 days to see if there is a reduction. If not, I reduce the dose, and of course, then I switch.
And then I think, Joyce, what do you do in older patients? You have your 82-year-old, 78-year-old. What choice of CDK4/6 inhibitor would you have first?
I think it depends on the biology of her disease. I use all 3 of the CDK4/6 inhibitors as was pointed out, with patients with comorbidities and polypharmacy, I tend to not use ribociclib for those patients. If the patient has aggressive disease, though, very aggressive disease that's really endocrine therapy resistant, I will use abemaciclib at a lower dose. I'll start at 100 milligrams, which in I think a lot of our experience is night and day with regard to the tolerability. If a woman has small volume bone only that is largely asymptomatic, I think palbociclib is an excellent choice.
And how, for patients who have specific comorbidities, would you select? We saw data today about patients who had sort of different extent of disease and comparing in a real-world database different CDK4/6 inhibitors.
Yeah, there's a lot of actually very interesting real-world data that you can look at from this meeting. And some of them have suggested that to the extent there are subtle differences in the longer-term outcomes, perhaps it's more easy to see those in patients who have visceral metastases or more worrisome or higher-grade lesions, which perhaps might, I mean, if you have visceral disease in the liver, you might not use ribo, but might push you perhaps to use abema over palbo. I confess I use a lot of palbociclib. I find it a really well-tolerated product, and I'm not so swayed that there's actually a survival signal for one of these drugs or another. I'm going to have the chance to show you some of those data in the moment.
Great. Well, let's go on to the next video here and PIK3CA mutated disease.
The last-minute San Antonio breast cancer presentation of triplet therapy in patients with PIK3-positive, metastatic ER-positive, HER2-negative disease has sparked a great deal of interest in oncologists in the community.
62-year-old woman who's hearing impaired, she presented with a de novo metastatic disease, which was ER positive, HER2 negative, HER2 0. And she had bone mets at the time of diagnosis, a palpable breast mass and axillary adenopathy, but rather asymptomatic from her disease. At the time of diagnosis, we could identify PIK3CA alteration on her blood. So, would this be a candidate for the triplet therapy, utilizing therapy directed towards PIK3CA alteration along with the AI, which is aromatase inhibitor, and the CDK4/6 inhibitor? Would that be a good combination, maybe if not now, maybe in the future? What do investigators think about that?
So it's a great question. And so, Sara, just to ask you, do you think that clinicians and community-based clinicians should assess PIK3CA mutation status right at diagnosis for HR-positive metastatic disease?
At this point, no. But if inavolisib is available, then I think we're going to be compelled to do so. I tend to do it a little bit later after the first-line setting because I want to capture the evolution of ESR1 mutations. But I think we're probably going to see that we're moving up.
And we'll hear about the INAVO120 trial, but if you had the triplet available to you, would you use it in the same population? So the more, like this patient was a de novo patient, but INAVO120 looked at patients who'd had more endocrine-resistant disease.
Yes, I think I would follow the study design, which was much more endocrine resistance, and I would also call out the fact that we must be very mindful of the patient population and the restrictions based on HbA1c. These were highly selected patients, and we need to be careful because of the risk of hyperglycemia.
Good point, and we'll hear a little bit more about that from Hal.
Great. Well, thanks. It's great to be with you. I admire your stamina after 4 days of ASCO to come out and hear more about cancer. So hang in there. It's good to see you all. So I was asked to talk about first-line therapy for hormone receptor-positive advanced disease. And these are the data for the 4 randomized trials that looked at first-line treatment of a endocrine therapy with an aromatase inhibitor given with or without a CDK4/6 inhibitor. The endpoint for all these studies was progression-free survival, and they all had almost superimposable identical PFS estimates, regardless of which CDK4/6 inhibitor was used. With longer-term follow-up, a couple of studies actually showed a statistically significant survival difference, including the Mona Lisa trials. There was a 1-year improvement in overall survival in the Monarch 3 study, but it did not reach statistical significance. So those are some of the data that people have been alluding to. It is important to remember that these are not head-to-head studies. These studies were done in different parts of the world. The Paloma trials were largely done in Eastern Europe or Russia. The Mona Lisa platform was largely done in Western Europe with some U.S. accrual. And so you have to wonder a little bit about the kind of care people get beyond progression and the patients who went into the study at the various times. Perhaps in support of that overall idea, there's a recent report of the Parsifal study, a de novo treatment looking at fulvestrant versus letrozole as the endocrine partner for palbociclib, showing a now median overall survival of 66 months for patients who get palbo. I think that 66-month number is really something important to remember. Your average patient with ER-positive metastatic disease has a 5+ year life expectancy. And there was a very nice real-world study from the Italian groups presented this afternoon. And again, the median overall survival was about 65 months from 18 centers across Italy looking at use of CDK4/6 inhibitors in that experience. These drugs were also all analyzed in the second line. Patients would have had an aromatase inhibitor and then fulvestrant given with or without a CDK4/6. Similar kinds of things here, some trends towards survival, some of them reaching statistical significance. Adding to this are some real-world data we saw at ASCO in the posters yesterday. There was a study from Poland that that palbociclib did not necessarily improve overall survival, while ribo might have and look to. There was a US-based SEER registry that palbo did improve overall survival, and there was the Italian study that maybe suggested that abema and ribo might be a little bit better than palbo, but they weren't all accrued at the same time, and I think there is still some bias here. So personally, I use all these drugs interchangeably. I wouldn't try too hard to modify the dose. The companies don't think the dose is important. When they did the adjuvant study, the NATALY study looking at ribociclib, they actually dropped the dose from 600 down to 400. There's been a randomized study from the NCIC that compared palbo at 125 versus 100. It was exactly the same. So I think you have a lot of flexibility on both agent and dose. And that's something I share with patients, and then we talk about side effect profiles a lot. I think a couple of the more important lessons that have come along since the original wave of data for CDK4/6 relate to whether this class of drugs can be used instead of chemotherapy for patients who have visceral disease. And the Right Choice study was a very nice study and one of the first trials in decades to really compare an endocrine-based approach versus a chemotherapy approach in a first-line setting of patients who were said to have aggressive disease, symptomatic visceral metastases, rapid tumor progression, near visceral crisis, if you will. And they were randomized to ribo and letrozole or a different AI, and if they were premenopausal, given actually, they were all premenopausal. They were all given ovarian suppression at the same time versus a doublet of chemotherapy. And what they showed in that study, which is published online at the JCO now just a few weeks ago, was actually the group that did better with respect to progression-free survival and time to tumor treatment failure, and overall survival was the same, but the group that did better initially was the group that got the endocrine-based treatment. So even in patients who have reasonably heavy burdens of disease at the time of presentation with ER-positive metastatic breast cancer, your treatment of choice should be an endocrine approach built around a CDK4/6 inhibitor and other treatment. A similar study was done in Korea, perhaps with a less heavily cancer-burdened group of patients, and they compared palbociclib with an aromatase inhibitor, plus again leuprolide in premenopausal women, and compared that against capecitabine, and again the progression-free interval was superior with the endocrine therapy approach. So really important conceptual idea, if you see a patient who has liver mets or other visceral disease, short of extraordinary symptomatology, endocrine therapy is the way to begin the treatment. What about continuing CDK4/6 inhibitors after an initial wave of treatment? There have now been several studies that have looked at this. The PACE trial looked at palbociclib after palbociclib and did not show a major benefit. The MAINTAIN study looked at ribociclib after palbociclib and showed a modest improvement in second-line progression-free survival. And what we learned at this meeting was the so-called post-MONARCH study, which was abemaciclib and fulvestrant compared to fulvestrant alone after prior AI with a CDK4/6 inhibitor. The data were presented by Kevin Kalinsky. I would argue that these data look to be statistically significant, but I'm not sure they're clinically significant. There was only a 0.7-month improvement in median progression-free survival. So what I do know is that all the time, all of us and all of you will take a patient who's had first-line CDK-based therapy, they'll get another line of treatment, or you'll just switch them to a different CDK4/6 inhibitor. And actually, there was a patterns of practice poster presented, and it turns out already 40 to 50% of patients patients get at least 2 CDK4/6 inhibitors in the course of their illness in the United States. So that's already happening all the time, and I think that's perfectly reasonable, but there's probably not a lot of huge, heavy evidence to suggest that that radically changes the natural history of the disease. What about other approaches? Well, the case that was discussed by Dr. Agarwal was asking a question about using PIK3CA inhibitors at the same time. So we know that PIK3CA mutations happen in about a third of breast cancers. There are a handful of specific sites that contribute to this. And we already have targeted drugs in this space with alpelisib, the original PIK3CA alpha-selective drug, and more recently capivasertib, which is an AKT1 inhibitor, but also indicated for tumors who have mutations in the PIK3CA alpha pathway. These drugs differ in a little bit here, and for extra credit tonight, as you leave the room, there'll be a small test, and we will ask you to draw some of these organic compounds to contrast which of the PIK3CA inhibitors you might want to use. Perhaps some of them have slightly different binding affinities for the alpha subunit of the PIK3CA. If anybody's actually worried, there is no test. Perhaps there's also some protein degradation that happens when these drugs bind, and some of the argument for inavolisib being a particularly potent PIK3CA inhibitor relate to its ability to actually lead to degradation as opposed to just enzymatic inhibition of the 110 alpha subunit. So preclinical models suggested that combining the CDK4/6 inhibitor with endocrine therapy and then serially adding what is labeled here as GDC0077, which is now inavolisib, would be clinically valuable. And the INOVA 120 study validated that. I think the point that Hope was alluding to earlier is really important, which is that this was not a case, as Dr. Agarwal would have described, of de novo metastatic disease. This was a group of patients who had highly endocrine-resistant tumors recurring on or within 12 months of adjuvant endocrine therapy, whose tumors harbored a PIK3CA mutation, and they were randomized to this doublet of fulvestrant plus palbo versus the same with the addition of inavolisib. And to my surprise, two things. One is actually it made a big difference in progression-free survival. I actually hadn't expected that much because, to be honest, I don't think that most of the existing CDK4/6 inhibitors radically change the PFS as much as we've seen here, which is on the order of about 8 months, perhaps because we use them in later line of treatment. The other was that it was feasible to give this, because I would have guessed that the traditional issues of hyperglycemia, diarrhea, rash that you see with this class of drugs would be prohibitive. Intriguingly, there was actually perhaps a signal of a survival benefit, longer follow-up needed, but that would be remarkable, as again, we've not seen survival benefit with capivasertib or alpelisib or everolimus, the older drug in the space to date. Higher response rate noted as well. So this is the list of the side effects. You do still see mucositis in the combination. You do still see some hyperglycemia. It is not a trivial regimen to get through, but it was feasible. And so important to see where FDA goes with this, obviously, but perhaps for endocrine resistance, a nice triplet regimen. So I'll just conclude by saying that just a couple of months ago, we tried to update the ASCO guidelines for management of endocrine therapy options, and it's getting really hard to do that because of the genomics. You want to look for ESR1 mutations, you want to look for PIK3CA mutations, because of the vagaries of whether you've had adjuvant aromatase inhibitor therapy or not, because that shifts what your first-line regimen is. And I think that this is going to get actually more complicated, not less complicated. There are all these SERDs and PROTACs and other active endocrine agents waiting to enter this space, and there are next-generation CDK inhibitors that are also waiting to enter this space. So the good news is we're going to have more and more endocrine-based options, almost always now in combination with targeted therapies. But the bad news if you're someone who tries to write a guideline is it's getting very hard to look and see what, classic first line, second line, third line is going to be, because there are a lot of variables that go into it.
Wonderful. That was great and really interesting new data. And I know that Inavo has breakthrough designation, so we'll see what happens later this year. So we're going to move on and talk about what happens after CDK4/6 inhibitors now. And first, we're going to start and hear a little bit about toxicity profiles of PIK3CA inhibitors and SERDs. Let's hear what Neil has to say.
The management of patients with disease progression on hormonal therapy and a CDK inhibitor has become much more challenging with the introduction of a number of new biomarker-directed agents in this space, and there are many questions from oncologists in the field about how to make treatment decisions and minimize treatment toxicity.
Alpelisib has some concerns for hyperglycemia. I would love to review the data if capivasertib is a little bit better tolerated, if we can be a little less afraid of that. I haven't personally used it yet, but I think sometimes we will try to reach more for chemo first rather than the PI3CK because of that toxicity profile. And I would hate to, out of knowledge gaps, do that if the cabozantinib is better tolerated. I think the elacestrant is an interesting option if there is ESR1 mutation in the second line. I would love to go over the toxicities that we need to be looking out for. How different is it from fulvestrant? How efficacious can we expect it to be? And then do we really think that these targets should be unilaterally applied? Or if someone is having a visceral crisis, we really don't want to be relying on those targets and we actually just want to go to chemotherapy next.
In terms of subsequent therapy for patients with HR positive, HER2 negative disease after progression on CDK4/6 inhibitors, if the molecular testing shows both PIK3 AKT/PTEN alteration as well as an ESR1 mutation, how would the faculty choose the next line therapy between, for example, fulvestrant with either capivasertib or alpelisib versus elacestrant? In a patient with PIK3 AKT/PTEN alteration, first of all, how do they decide to choose between fulvestrant with either capivasertib or alpelisib? And also, how would you manage for patients with pre-existing diabetes?
A lot of questions we won't have time to go through, but we'll start and just talk a little bit about the second-line therapy you'd recommend in a patient who has disease progression 18 months after starting a CDK4/6 inhibitor with an AI. And as you do the testing, they have a PIK3CA mutation. And how would you change this if they also had an ESR1 mutation and if the patient had very rapid disease progression after 6 months? Aditya, do you want to start with that?
Yeah, absolutely. This is not an uncommon scenario. You can have both PIK3CA and ESR1 mutations in this setting. And the options would be elacestrant, fulvestrant in combination with capi, or fulvestrant in combination with alpelisib. We don't have head-to-head comparisons between these options, so there's no direct comparison. It's from the clinical trials that were done. It's reasonable to use any of those. I think it ultimately boils down to the safety profile. It's often elacestrant would have less AEs as compared to fulvestrant abema or fulvestrant and capi, so that's a reasonable option to start with. And then after that, you can use more of a combination approach. But it also depends on the individual patient, so ultimately require patient-centered discussion. The only other thing I would add is while we don't have biomarker data related to ESR1 from the CAPI trials or the alpelisib trial, we do have biomarker data from EMERALD, which showed that patients who had double mutant, both ESR1 and PIK3CA, the benefit of elacestrant was maintained as long as the prior duration of CDK4/6 inhibitor was more than 12 months. So for the first patient, because the CDK4/6 duration was 18 months, I would feel comfortable with elacestrant. But for the second patient who had rapid disease progression, I would probably consider combination therapy.
And then, Giuseppe, if a patient started a CDK4/6 inhibitor with an AI and has just the ESR1 mutation, do you follow the same approach that Aditya mentioned, where you're giving elacestrant or not, and a drug that affects the PIK3CA pathway or not?
No, personally, no. You know, if you have a frontline patient, for sure this is endocrine sensitive, so I would go with a standard of care. So even if there is an ESR1 mutation, I would give an aromatase inhibitor. This is really essential to be understood because finally, elacestrant was a drug that was tested in the second line setting, not in the first line setting. Until now, we don't have data on the first line setting.
And Joyce, do you take the same approach? What do you do in a patient who has a PIK3CA and ESR1 mutation, both who say is progressing at 18 months versus 6 months?
You know, in this scenario, of course, in both cases, you don't have an outstanding median progression-free survival, both for capivasertib, in which after CDK4/6 inhibitor, median PFS is 5 months, and similar data also for elacestrant. So maybe this is a patient where I would consider or a chemotherapy, or HER2-low, eventually, trastuzumab deruxtecan, since now we have this option in this setting.
Joyce, do you take the same approach?
If she's got the double mutant and she's minimally symptomatic, lower tumor burden, feeling well, I want to optimize her quality of life, diminishing side effects of the therapy. So I would go with elacestrant, was 5.5 months median PFS in the EMERALD trial in patients with the double mutants. And in the wild type, it was higher, like 8 to 9 months median PFS. It was a little bit less, but that means half of the patients go longer than 5.5 months. So I would prioritize the elacestrant and then come back later on and go after the PI3 kinase pathway.
And then just last very quickly, Sarah, do you have any thoughts about, camizestrant, imlunestrant, elacestrant? We don't have phase 3 data yet on those drugs. Do you have sort of a feeling about efficacy, tolerability?
So the efficacy, no. I think, we're not seeing that one is, way out front in the horse race. So we're going to have to see how the studies report out. And we're not going to have head-to-head comparisons. We're just going to have to do what we did with anastrozole, exemestane, and letrozole when all the data came out. In terms of tolerability, we're seeing some bradycardia and GI side effects, but maybe less arthralgias, depending on the study. So I think we're just going to have to watch it closely.
Yeah, it's been interesting. We'll talk now about selection and sequencing of treatment for patients with HR-positive, HER2-negative disease progressing on CDK4/6 inhibition. And clearly, this is a high unmet need now. This is an area where, of course, our patients are receiving CDK4/6 inhibitors in the first line, largely, with few exceptions, and will be receiving them in the adjuvant setting. So it's going to become more of an acute issue for us, understanding the various pathways that are activated to try and target the right resistance pathways, and also to understand true resistance where we might need to go to an ADC type approach early, and we'll hear about that in a little bit. ESR1 mutations are interesting. We were talking about this. When patients develop metastatic disease, if it's not on their aromatase inhibitor, the rate of ESR1 mutations is quite low, in the 5% range, and in the adjuvant setting in untreated patients, it's very, very low. But as you treat patients under the pressure of treatment, you start seeing increasing percentages, so that by the time patients have received a lot of first-line therapy, in the second or third-line setting in those who didn't receive as much, you get up to 40% of patients who have ESR1 mutations, and longer exposure increases the chances of getting an ESR1 mutation. And then one of the questions that comes up a lot is whether or not we should be looking at tissue. So should patients be having multiple biopsies, or looking at ctDNA, where you can just get a blood test for patients? And there continues to be some questions about this. But there is actually data that suggests that you're a little bit better at finding ESR1 mutations in the blood than in tissue. And unless you're looking for ER and HER2, it actually is better to be testing liquid biopsy or ctDNA for ESR1 mutations, and this is in Hal's updated ASCO guidelines in 2023. So the idea, and this is courtesy of Nick Turner, who gave a talk on this at ESMO Breast, that you would, with first recurrence, you'd get a tissue biopsy to confirm it's breast cancer, because we've all seen occasionally it's a different cancer. You want to look at receptors to look at ER, PR, and HER2. Occasionally we get a surprise and it's HER2 positive. You can look for PIK3CA, AKT1, and PTEN abnormalities, including PTEN large deletions that are really only found in tissue biopsies. But this is conserved, so you can do that in your original tissue biopsy. And then, of course, you want to do germline testing. And then you do your first-line treatment with an AI and CDK4/6 inhibitor. And as patients progress, you're going to be doing liquid biopsies to look for acquired mutations, both ESR1, the PIK3CA pathway mutations, and then also we may be looking for somatic mutations as well in both BRCA and HER2. So this is, of course, assuming that you have all the testing available. And what do we know about ESR1 mutations? Well, this is data now published in 2020 that looked at a combined analysis of two trials, SOPHIA and EFFECT, that randomized patients who had progressed on an aromatase inhibitor to receive fulvestrant or exemestane, and they looked equal until we looked at ESR1 mutations, and it turned out that fulvestrant was far superior than exemestane in patients who had mutant ESR1. And here you can see that in just progression-free and overall survival. So that led to a lot of interest in looking at selective estrogen receptor downregulators that might be able to overcome the resistance, but not be an injection that you get 2 injections every month. And all of us who treat patients have a lot of patients who really don't like those injections much and hate coming in. So we were excited to see the initial data from the first approved oral SERD, elacestrant, versus standard of care therapy. But the hazard ratio is quite good, but there was a big fall off. And you can actually see that on that patient group on the far left, where there's about 40% of patients who progressed by their first scan, because this included a group of patients who have real endocrine-resistant disease, and you couldn't really ferret out those patients. So there was some question about how to figure out the optimal benefit in the patient population with elacestrant. And here there was the sort of look at an unplanned analysis looking at a surrogate marker of endocrine resistance. How long did patients stay on a CDK4/6 inhibitor? So here you can see that patients who stayed on for 12 months or longer had a very big benefit from elacestrant versus standard of care hormonal therapy, including when that was fulvestrant, from 1.9 to 8.6 months with a hazard ratio of 0.4. And there is a benefit even in patients who are 6 months or more, but it becomes quite dramatic when you get out to 12 months or more of the CDK4/6 inhibitor. This data and the data looking at patients with ESR1 mutated disease led to approval by the US FDA in January of 2023 with a companion assay of Guardant 360 so that you can look in blood and don't need tissue. The EMERALD trial, as noted earlier by Aditya, looked at different mutations, and these are small subset analyses, but it appeared that the benefit in patients who'd been on a CDK4/6 inhibitor for at least 12 months was maintained whether or not patients had PIK3CA mutations, HER2 low expression, TP53, or visceral metastases or bone metastases, as you can see in the median PFS and elacestrant and versus standard of care, as well as in the hazard ratios. So that was very encouraging. So it does suggest you could take Joyce's approach in a patient who doesn't have immediately life-threatening disease. So, of course, there's a lot of interest in expanding our oral SERDs and new SERMs, as well as CERCAs, PROTACs. We heard about one today as well. And these all work. There's also SERONs. They work by different mechanisms. I think my favorite is the blocking ubiquitinization of the estrogen receptor, because it's such a cool word for the PROTACs. And these agents are all in clinical trials. We have a little bit of data from the phase 2 SERENA-2 trial looking at camizestrant versus fulvestrant that looked as though camizestrant resulted in better efficacy, particularly in patients who had ESR1 mutations. And here you can see some of the summary of data with different combinations of therapies, the imlunestrant and serin monotherapies, imlunestrant and alpelisib and everolimus. These are all small subsets. The PROTAC called Vepdeg or vepdegestrant, and palazestrant, which is a serin. And then there's a combination study with imlunestrant and abemaciclib as well. All of these showed very nice responses in general tolerability. There's many additional phase 3 oral SERD trials for metastatic breast cancer, some of them shown here. EMBER-3 is expected to report out potentially by the end of the year. And it's interesting because it's relatively unique looking at imlunestrant alone versus imlunestrant and abemaciclib. And then, of course, investigators' choice therapy. All of these are looking at the subset of patients who have ESR1 mutations as well as overall. Giredestrant is looking at a triplet combination, SERENA-4 with camizestrant. And then SERENA-6 is unique because it's monitoring patients for the development of ESR1 mutations without systemic progression, and then changing the endocrine therapy to the oral SERD while continuing the CDK4/6 inhibitor to see if by early intervention before systemic progression that we can change outcome. And then there are a number of other trials that are being done, and you can see all the different agents here, giredestrant, camizestrant, imlunestrant, and then elacestrant, because we all want the combination data, and the ELEVATE trial is looking at various combinations with CDK4/6 inhibitors, everolimus, and capivasertib. The PROTAC has a number of different combination studies and then phase 3 trials, as does the sarin palazestrant. So what about inhibiting AKT? We talked about the fact that we might want to use an AKT inhibitor like capivasertib, now approved in patients with PI3 kinase pathway mutant disease, rather than alpelisib because of differential toxicity. And in an initial phase 2 faction trial, we did see improvement in progression-free survival, particularly in the pathway-altered patients. In Capitello 291, we looked at patients who'd had progression on 1 to 2 lines of endocrine therapy, up to 1 line of chemotherapy, and patients received capi or placebo with fulvestrant. And then the endpoint looked at the overall intent to treat population as well as those with AKT or PIK3CA altered tumors. And most of the patients had received 1 line of prior endocrine therapy. This was interesting data because about 40% of patients had overall mutations, so any pathway alteration, 44% overall. And some of the patients didn't have mutations, hopefully, that could be tested in tissue. Hopefully we'll have blood analysis in the future. We saw an improvement in progression-free survival, both in the intent to treat as well as in the altered population. But you can see the hazard ratio is a little better in the AKT pathway alteration, which led to altered population, which led to the FDA approval in that group. And then looking at the different subset analyses, it looked like capivasertib was superior in most of the subset that we could look at here. And overall survival hopefully will be available later this year. In terms of safety, capivasertib has diarrhea and rash primarily, and not so much hyperglycemia. Patients could go on to have a hemoglobin A1C up to 7.9%, and we didn't see much hyperglycemia except for in patients who didn't stop the drug after 4 days, which was a tiny number of patients. But you take it 4 days on, 3 days off, and this stomatitis is managed very well with a steroid mouthwash. We've used antihistamines and antipropulsive agents in managing the toxicity very well. And then at ESMO this year, we showed progression-free survival too. So most of the patients received chemotherapy after progressing on capi fulvestrant or placebo fulvestrant, and the overall PFS benefit was maintained. And you can see the hazard ratio in the altered population is 0.52. So there are a number of studies ongoing, and similar to Inavo 120, you heard about CAPI 292 is looking at fulvestrant with a CDK4/6 inhibitor plus or minus capivasertib, and ribociclib and abemaciclib combinations will enter this trial. There are a number of other trials going on, including the gedatolisib trial that is a combined mTOR PIK3CA inhibitor in the Victoria 1 trial, and a number of new mutation-specific PIK3CA inhibitors that are in early clinical trials now. And we heard about Inavo 120 earlier. And then lastly, there's a novel SERM called lasofoxifene that showed very nice data in combination with abemaciclib and is currently being studied in a randomized trial called ELAINE 3. And we heard about post-MONARCH earlier. CDK4/6, we know CDK4/6 inhibitors. There's a CDK4 inhibitor in a phase 3 trial in metastatic breast cancer, very efficacious, less neutropenia, 510 patients being randomized in the second-line setting to fulvestrant with everolimus. With fulvestrant or everolimus exemestane versus the CDK4 inhibitor with fulvestrant. And a phase 3 first-line trial will open later this year with a CDK4 versus CDK4/6 inhibitor with letrozole, thinking about the fact that we're going to be having a lot more patients with metastatic disease who've gotten 4/6 inhibitors in the early stage setting. So let's go on and talk about HER2-low and ultra-low disease. This was really the I think, biggest topic in breast cancer at this meeting. And we're first going to hear from Dr. Agrawal with an introduction by Dr. Lowe.
The use of TDXD in HER2-low ER-negative patients is also an important consideration, as demonstrated by a case from Dr. Agrawal.
I have a young patient, 42 years old, who has a diagnosis of recurrent metastatic triple-negative breast cancer 1 year after completing the Keynote regimen in the curative setting. So she underwent the neoadjuvant portion. She actually had a complete pathologic response, had her breast surgery, radiation, completed the adjuvant immunotherapy, and then 1 year later had a metastatic recurrence in the liver. So this patient now has had anthracycline and taxane and platinum. So how do you decide what you would use as the first line of treatment for metastatic triple negative breast cancer? And this patient had PD-L1 negative at this point. The original breast cancer was HER2 1+, but the biopsy of the metastatic site was HER2 0. Does that impact, or how do you interpret, or how do you factor in the original breast HER2 status versus the metastatic? What's your approach there?
Great. Well, we'll talk a little bit about this now before we get into our presentation on HER2 low and ultra low disease. So how do you approach patients with TNBC? They've had Keynote 522, they've developed metastatic disease. Do you re-challenge, and how do you take the disease-free interval into your thinking?
It's a tricky problem, right? Because when you've gotten the Keynote 522 regimen, you've given 4 flavors of chemotherapy already, plus the immunotherapy. And if they recur within a few months or a year, we typically would not re-challenge with the immunotherapy. In fact, they might still be on the treatment. For those patients who have had a wider disease-free interval, it's very fair to test for PD-1, PD-L1 expression and see if they're a candidate for ongoing pembrolizumab or reintroduction of pembrolizumab. And you can use it in combination with either a taxane or with gemcitabine carboplatin based on the FDA label. But let's acknowledge the obvious. These are very challenging patients to treat. We often end up using drugs that are rather old. We're using capecitabine, we're using eribulin. It's a space where now, if the tumor is HER2 low, we're thinking about an ADC with trastuzumab deruxtecan, and we also have the sacituzumab ADC, which is an important option for these patients, and if they recur really quickly, they might be candidates for that as really a second-line drug. But these are tough tumors, and a rapid progressor like that is very challenging.
So, Joyce, if you have a patient who's HER2 1+, as was just described, and then on biopsy is 0, regardless, let's say it's ER positive, make it an easy case, would you offer TDXD? And how does the hormone receptor status then affect your plan?
We have the strongest data, as we'll hear from Giuseppe, for HR positive, HER2 low disease. So, but we have data from DB04 that even if you go back to an archival specimen 20 years ago where you had a 1+ and now your biopsy today is 0, that the patients can still benefit from the TDXD. So for the HER2 low decision, any of our biopsies will suffice. Now, of course, we're into the ultra low, which we'll hear about.
And Aditya, how do you sequence TDXD and sacituzumab in a patient with HER2 low disease? And how do you decide on that? Is it based on HR status?
Largely it is. So for a patient with HR negative HER2 low disease, I would generally use SG first, and then after that use TDXD, just because we have level 1 evidence from the ASCEND study that was just dedicated to TNBC, while DESTINY-Breast04 only had 10% of patients who had hormone receptor negative disease. But the other way around, if a patient has hormone receptor positive HER2 low disease, because the results in DESTINY-Breast04, the median progression-free survival, overall survival, just was quite remarkable. So generally use TDXD and then after that SG. But ultimately it's a patient-centered discussion. You talk about the side effect profile, the schedule, Q3 versus day 1, day 8, every 21 days, risk of pneumonitis versus diarrhea, nausea, and whatever agent you use, then you can use the other agent after that.
Great. So, Giuseppe, I'm going to have you start your talk on HER2 low disease, but as you start, maybe you can answer this question. You're going to talk about HER2 ultra low, so maybe you could talk about quickly how it's defined in DESTINY-Breast06, and maybe conclude with the final question at the end of your talk. Would you be offering patients with HER2 ultra low disease TDXD when you return to clinic, assuming it was available to you?
So there, 2 ultra low was defined as any staining between 0 and 1. And if you ask me if I am going to give trastuzumab deruxtecan to an HER2 ultra low population, I would say yes, and I will show to you why, because I will present the data.
Please go ahead.
So finally, before trastuzumab deruxtecan, of course, the traditional HER2 pie chart was HER2 negative and HER2 positive. And the HER2 positive disease was accounting only for 15% of the patients. And don't forget that ASCO-CAP was designed specifically to predict the patient population that was responsive to trastuzumab. So in my opinion, it's time to think about a new ASCO-CAP. I am speaking with Harold that is dramatically involved with ASCO. So here we have the ASCO-CAP, and you will see that you have an HER2 0, but HER2 0 doesn't mean that you don't have expression of HER2, because in an HER2 0 slide, you may find 10,000 to 1 million HER2 receptors per cell. So this is a real important point. A tumor is never HER2 0. It's the ASCO-CAP that defines this HER2 0. Then you have 1+ and 2+ with each non-amplified. That was the eligibility criteria to the DESTINY-4. So HR positive HER2 low account for 60% of HR positive population, and triple negative HER2 low account for 40% of the triple negative population. So this is not a distinct biology. Even if you have HER2 low disease, the prognosis will be exactly the same. If you are a luminal cancer, you have the prognosis of a luminal cancer. If a triple negative, the prognosis will be the one of a basal-like tumor. DESTINY-4 was designed to test activity of trastuzumab deruxtecan in HER2 low population, 1+, 2+, each non-amplified. All patients in the DESTINY-4 received 1-2 prior lines of chemotherapy, and they have been randomized to trastuzumab deruxtecan versus physician choice chemotherapy. The primary endpoint was progression-free survival by blinded independent central review. If you can see here, 60% of the patient population was 1+, 40% 2+. The majority of the patients were HR positive. There was a small cohort of patients that were triple negative, 58. The median of 2 prior lines of endocrine therapy and 1 chemotherapy is for the majority of the patients, and 70% of HR positive received prior CDK4/6 inhibitor. In the DESTINY-4, trastuzumab deruxtecan improved median progression-free survival from 5 months to 10 months, but improved also the overall survival in this patient population, both in the patient population intent to treat and hormone receptor positive. There was also a benefit in HR negative disease. That's why we are using trastuzumab deruxtecan in the triple negative population. Overall response rate was 52% in the DESTINY-4 for HR positive and 50% for HR negative. And the progressive disease, you can see here, was much more better, of course, in the trastuzumab deruxtecan arm. Of note, the benefit, according to HER2 expression, was almost similar. We have 10 months for immunohistochemical 1+, and 10 months for immunohistochemical 2+. These are the data of DESTINY-4. An updated analysis was presented at ESMO this year, and there is really a confirmation of the data of the primary analysis. So with the longer follow-up, there is still a benefit from trastuzumab deruxtecan in their HER2 low population. In terms of safety, a longer follow-up did not finally increase the risk of ILD. And this is also an important information. So the first concept is that HER2 low is unstable. So if you have an HER2 0 at the baseline, you have to test in the metastatic setting, because following exposure to endocrine therapy, you may have an upregulation of the epidermal growth factor receptor pathway, but you need 1+ in order to be eligible to trastuzumab deruxtecan. So what will happen for the future? So we designed the DESTINY-Breast06 because, there was an opportunity also to test trastuzumab deruxtecan in the so-called population of HER2 ultra low. Any staining between 0 and 1. So if your pathologist will give to you a report, HER2 0, you should ask, which is the number of cells stained, which is the rate of cells stained, because immunohistochemical 0 is anything between 10% and 0, but is never 0. So do we have data on HER2-0? Yes, in the DAISY trial there were 3 cohorts, 3+, 2+, and 0. And finally, you can see here that also in immunohistochemical 0, overall response rate was 30% with a median progression-free survival of 4.2 months. This was not a prospective randomized trial, it was just an exploratory analysis. Which is the difference between Destiny 6 and Destiny 4? In Destiny 6, we have only HR-positive disease. In Destiny 6, patients received a maximum of 2 lines of endocrine therapy, including CDK4/6 inhibitors in the first line, and no patient received chemotherapy. So this is exploring the activity of trastuzumab deruxtecan in early line respect to the Destiny 4, and having also a cohort of patients with HER2 ultra low. There was a cohort of 153 patients included. 730 patients were HER2 low, 153 HER2 ultra low. Primary endpoint was progression-free survival. The majority of the patients in the trial received capecitabine, and then nab-paclitaxel and paclitaxel. Here we have the key takeaways of the study. Trastuzumab deruxtecan demonstrated a statistically significant and clinically meaningful progression-free survival benefit when compared to chemotherapy in HR-positive, HER2-low, treated after 1 line of endocrine therapy, with consistent results in HER2 ultra-low metastatic breast cancer. So we will expand the possibility to use trastuzumab deruxtecan in almost 85% of the patients with HR-positive disease. Here you can see the median progression-free survival in the primary endpoint. There is a delta of 5.1 months, increasing from 8 months with capecitabine. These are the first data of performance of chemotherapy after CDK4/6 inhibitor. In this case, there is an really very good performance because, maybe patients have been selected since they received 2 lines of endocrine therapy. Maybe they are more sensitive. And then, of course, the median PFS in trastuzumab deruxtecan arm was 13.2 months. In the HER2 ultra-low, we have exactly the same benefit. Of course, we have a limited number of patients, but there is an increase of median progression-free survival from 8 months to 13 months. And also in this case, a trend for overall survival. Don't forget the maturity for overall survival analysis was 40%, so we don't have mature data to conclude on overall survival. And also many patients received trastuzumab deruxtecan on the control arm once they progressed. So which will be the future? What we are going to do in the Destiny 06 is to identify the minimum threshold to predict the activity of trastuzumab deruxtecan. So I believe novel quantitative HER2 testing is necessary, and we need also to revise the ASCO cap. And so in the future pie chart, actually, we expanded the use of trastuzumab deruxtecan in HR-positive disease. And really, it will be important to the future to better identify the clinical characteristics of those patients that can go directly to TDX after CDK4/6 inhibitors. Thank you.
That was great and so interesting. I mean, the data from DB06, I think, was quite striking and has influenced our discussion, and I'm sure we'll talk about that in a little bit when we get to the last module. But we're going to talk now about how we select and sequence therapy for metastatic triple-negative breast cancer, and we'll start with a video talking about the potential role of T-DXd in a patient who has HER2 mutation, and Dr. Love will introduce Dr. Gupta.
We've been focusing our attention on common situations in metastatic breast cancer, but I thought it might be interesting to consider this unusual situation for Dr. Gupta of a 42-year-old man who not only presented with metastatic disease, but had an exon 20 insertion mutation on liquid biopsy, something we talked about on Friday night in our lung cancer session. Anyhow, we'll be curious to see what the faculty thinks about this.
I had a 42-year-old male migrant who presented with de novo metastatic disease, which was ER, PR, and HER2 negative. He was actually admitted to the hospital with this large right breast lesion with spikes coming out from it, looked like stalactites and stalagmites, and bulky right axillary lymphadenopathy. He had this right breast mass, bulky axillary adenopathy, some swelling on the right side, adrenal mets, and subcutaneous nodules. Literally, subcutaneous nodules that you could palpate on the skin of his back, right upper back. I started him on gem carbo. His PD-L1 was negative. It's interesting that on his circulating tumor DNA analysis, I could pick up this ERBB2 exon 20 mutation or insertion, which was seen consistently, all across the board of his disease course. So I thought that this is probably the driver. We should target it, but not sure how to target it. And then came the data about lung with the HER2 mutation. But this is a mutation in a breast cancer setting. The insurance company would not approve TDXD.
Yeah, which is a tough situation, although I think the tide is changing some. Sara, how would you approach a young male patient? I mean, it doesn't matter if it's male or female, with de novo metastatic TNBC with this kind of situation.
Yeah, I think her selection of frontline chemotherapy, given that it was PD-L1 negative, was perfectly appropriate. I think probably in a taxane naive patient, if the performance status was good, I would have used taxane. But gem carbo is perfectly appropriate. I do think, given the HER2 mutation, though, in the later line setting, we have mounting data from the SUMMIT trial indicating activity of neratinib in this setting. And we have some other novel agents that are being looked at in this setting, including tucatinib. So I think trying to enroll this patient in a trial would obviously be great.
Yeah, but would you use the drug outside of a setting of a trial?
Not other than neratinib. I would use neratinib outside of a trial. I think the data are adequately impressive.
Giuseppe?
It's quite uncommon to have an HER2 mutation in the triple-negative breast cancer, as it is uncommon to have a triple-negative breast cancer in a male. So I would revise the central testing of ER, because in triple-negative disease, usually HER2 mutations are really common for HR positive. In any case, there is the Destiny Pan Tumor 01. We recently published it on the Lancet Oncology, and there was a cohort of patients with HER2 mutation, HR positive, that have been treated with trastuzumab deruxtecan with an overall response rate of 54%. So trastuzumab deruxtecan can be an option for this patient.
Yeah, I'm treating a patient now with TDXD with a HER2 mutation, and she's stayed on for a long time, so it can be. Joyce, how do you approach endocrine therapy for male patients, and if you have the primary, management of the primary for a male patient, would you do surgery if they present with metastatic disease?
Well, very similar to postmenopausal women, basically. They generally have endocrine therapy-sensitive disease. I think the exception is, we decide if they need chemotherapy in the same way we decide if postmenopausal women need chemotherapy. It depends on the biology of the disease. In men who have more ER-driven disease, where it's more indolent, maybe grade 1, 2, I tend to favor tamoxifen for them. That's a long-standing, very effective therapy. But if a man has grade 3 disease, I had a young man in his 40s who presented with an aggressive, really lytic, destructive, de novo metastatic, And we did not do any local surgery for his breast because he had this lytic disease and he had a very durable response with an LHRH agonist, AI plus palbociclib. Very, very durable, excellent quality of life.
Yeah, I have a patient exactly like that now, although he insisted eventually on having surgery. But
he was not a BRCA either, surprisingly.
Neither of mine either, not a BRCA patient. So I think, there can be a lot of variation, and we do see ER negative. I think it represents somewhere in the 5% range, depending in male patients. So, for triple-negative disease, of course, sacituzumab govitecan was the first ADC to be approved. So let's hear from Neil about Gigi's case.
A key option for patients with metastatic ER-positive, HER2-negative, and triple-negative metastatic disease has been the anti-TROP2 ADC sacituzumab govitecan, and our consulting oncologists were curious from the faculty on the stage about their approach to managing these patients, and particularly the use of growth factors.
We have had some experience with the sacituzumab, but in general, our experience is that patients have had a fairly good response with the treatment. I think the challenge has been the neutropenia, that's associated with this treatment, so I think patients, we have used growth factors. In some patients, I have done a 1 week on, 1 week off. So I'll be interested in terms of the faculties, what they recommend in terms of side effect management for sacituzumab.
Yeah, I've actually been hearing that at this meeting that some people have given every other week. Aditya, how do you approach neutropenia and use of growth factors?
Yeah, neutropenia is a common side effect seen with sacituzumab govitecan. Grade 3 or higher neutropenia being 50%. So it is a side effect you'll see when you use the drug. Generally, primary prophylaxis is not recommended, but secondary prophylaxis is recommended. So if you do see neutropenia, use of short-acting, long-acting, depending on whether it's day 1, day 8. Interesting idea to use SG every 2 weeks, then you can use the long-acting form of GCSF, very similar to how we do dose-dense chemotherapy. Reason it was not done initially in the clinical trial is because of PKs. Technically, SG should be given weekly. The reason it's given day 1, day 8, every 21 days is because of neutropenia. You just cannot give it every week. So from that perspective, I think we should continue with day 1, day 8, every 21-day schedule. But if you're really running into issue, you can either skip day 8 or try this, I guess, every 2-week schedule.
And I think, sometimes we do use prophylaxis up front, even though that wasn't part of the trial, in patients who previously needed growth factors for something. It doesn't make any sense because then they come in at day 8, they're neutropenic. So then we'll start with growth factors. You can always back off. And that's generally been our approach with use of sacituzumab regardless. But let's hear a little bit about the sequencing of therapy for patients with metastatic TNBC from Joyce.
Great. Well, let's start out and look at where we are today across the top. There's basically 4 categories of treatment approach in the first-line setting for metastatic TNBC. We need to know PD-L1 status, ideally on the metastatic lesion, but if not, we can go back to the primary. We need to know BRCA status, germline BRCA status, and I think I would put in a germline PALB2 here as well. And so if a patient is wild type for BRCA1, 2, PD-L1 positive, we would go ahead with chemotherapy and pembrolizumab. If she's negative for both, taxane or a platinum-based regimen. If she is negative for PD-L1 and BRCA or PALB2 mutant, then a PARP inhibitor. And if she's both, I think many of us would start with chemotherapy and pembrolizumab because of the survival advantage of that regimen, and then reserve the PARP inhibitor for second line. Generally speaking, I think many of us will go to sacituzumab govitecan in the second line because, as Aditya said, the level 1 evidence from the phase 3 trial in the triple-negative breast cancer patients, and then sequence to the HER2, for the HER2 low patients, sequence to TDXD, and then we have other single agents that we consider after that. So that's a general algorithm. We're well aware of the Keynote 355. This just justified our use of for the 38% of patients who are CPS 10 or more. We get a survival advantage with chemotherapy plus pembrolizumab in the first-line setting, as we see here, just about a 7-month improvement in overall survival. So that's why this regimen, of course, is prioritized. We saw these data in Passion 132 at ESMO Breast. They've already been published in Annals of Oncology. And in this trial, patients received first-line chemotherapy with capecitabine or gemcarbo with or without atezolizumab. But these were early relapsing patients. They were recurring within 12 months post their neo or adjuvant chemotherapy and or surgery. They had to have had prior anthracycline and a taxane. And as you can see here in the intent to treat population, all comers, as well as in the PD-L1 positive group, there was no improvement in survival, adding this, in this case, atezolizumab to chemotherapy, even in the PD-L1 positive. So these rapidly recurring patients are a different biology than the patients who were treated in Keynote 522. There was a subset in Keynote 522 where if they were at least 6 months out, they were between 6 and 12 months out that they recurred, that they could enter the trial and get gemcitabine carboplatin. So there was that group in there. They didn't do quite as well with the chemotherapy and pembrolizumab as patients who had at least a year treatment-free interval. So I think in general, going back to a PD-L1 or a PD-1 inhibitor going back to pembrolizumab in this early relapsing group of patients is not a fruitful strategy for the patients. Now, we know very well if somebody is germline BRCA positive, and we heard today about germline PALB2 as well, that the PARP inhibitors, olaparib and talazoparib, are good options for these patients. And these are updated data from the Olympiad trial looking at patients who had had no prior chemotherapy for metastatic disease. So this is first-line use of olaparib versus chemotherapy physician's choice. It was 87 patients, and you can see a very nice improvement in overall survival here from 14 to 22 months. So this is, I think, the earlier we use the PARP inhibitors in these patients, and that's why on the algorithm for patients that are PD-L1 negative and germline positive, this would be a really excellent choice for those patients. Get it up front for them. Of course, as we're getting away from chemotherapy, and we have a number of antibody-drug conjugates that are either established in metastatic triple-negative breast cancer or coming along soon. So I'll just update you on both of these strategies. These are the final data from the trial that Aditya led for us with the sacituzumab govitecan in patients that had a median of 2 prior regimens in the metastatic setting versus chemotherapy physician's choice. And the survival was about a year with the sacituzumab and about half that with the chemotherapy. So clearly a very large improvement in overall survival, which of course is why this agent is prioritized. There was a very interesting trial reported by Peter Schmid at ESMO Breast just a few weeks ago from the Morpheus trial, and these patients in the first-line metastatic setting received, were randomized. It was actually a 3-to-1 randomization to nab-paclitaxel atezolizumab versus sacituzumab govitecan. With atezolizumab, they were PD-L1 positive. It was a small trial, but you can see responders here with the blue being SG and atezo, and here's the clinical benefit rate over here. So there was an improvement in patients' response rates, but even more impressive, here we have PFS, here we have duration of response, and these are, again, PD-L1 positive patients. And this is an impressive level of activity here with immunotherapy, in this case, atezo, with sacituzumab. So I think this bodes well for ongoing trials that I'll show you here in a second. And basically, this was to show us that they found out that patients who had stronger staining for TROP2, had more infiltration of CD8, were more likely to benefit from the addition of the atezolizumab to sacituzumab. But you can see this waterfall plot is actually really very, very nice. So that bodes well, I think. And so in the, we're waiting on this trial here. This is an interesting trial in PD-L1 negative metastatic triple-negative breast cancer patients as well as hormone receptor positive. We heard data from the SASI-IO trial, and for the HR positive here at ASCO, we're awaiting the results from the metastatic TNBC, and these are patients that are PD-L1 negative, first line, randomized to sacituzumab plus minus pembrolizumab. So we await that with interest, but the ASCENT-03 trial is for patients that are PD-L1 negative, first line, sacituzumab versus chemotherapy physician's choice, and ASCENT-04 are for PD-L1 positive patients, sacituzumab with pembrolizumab versus treatment of physician's choice with pembrolizumab, the KEYNOTE 355 regimen. So sacituzumab is definitely moving up into the first line setting. These trials are well into their enrollment, so that will be great. We've already seen from Giuseppe that TDXD is an option for us. About 58 patients here in the DESTINY-Breast04. Impressive level of activity, both on PFS and OS. And so that is a to follow in my practice pattern, to follow the sacituzumab. And I won't belabor this. We do know, or we've already talked about, the ILD rate, particularly more heavily pretreated patients, and we want to be scanning non-contrast chest CT scans to find the ILD before it's symptomatic, when it's grade 1, so we can interrupt, treat the patient with steroids, and go back to this very, very good agent and not have to stop it permanently. So the other TROP2-directed antibody-drug conjugate, there's 2 more. One is datopotamab deruxtecan, so the same topo-1 payload as TDXD, has a DAR, a drug-antibody ratio of 4. It targets TROP2, and it has the deruxtecan on it. And in TROPION-PanTumor01, these are pretreated triple-negative breast cancer patients, and that's a very impressive level of activity in a pretreated population. This agent has less in the way of myelosuppression, but it does have some stomatitis, and it appears that prophylactic use of steroid mouth rinse will really help decrease this rate of stomatitis, but it does not really have the myelosuppression. So datopotamab in the Begonia trial has been moved into the frontline setting in first-line metastatic triple negative in combination with the anti-PD-1 antibody durvalumab. And so this is the very impressive waterfall plot here by Peter Schmid. You can see the response rate of 79, but it's very intriguing here. L is low on PD-L1 and H is high on PD-L1. And you see most of these patients are low. There are some highs in here, but regardless of PD-L1 status, this is an amazingly effective combination, albeit in this phase 2 trial. So the datopotamab is in several trials now. The TROPION-Breast05 is ongoing. That is for PD-L1 positive patients. It's with datopotamab and durvalumab, as in the Begonia, versus the Keynote-355 regimen. TROPION-Breast02 is in PD-L1 negative patients, datopotamab versus investigator's choice of chemotherapy, and TROPION-Breast04 is preoperative. It's durvalumab and dato for 8 cycles versus Keynote-522, and then TROPION-Breast03 is for patients who have residual disease after preoperative therapy, and they get datopotamab durvalumab versus pembrolizumab capecitabine, and there is a small group of patients that get datopotamab alone. So this agent is already in the curative setting. It's in the first-line setting, both in PD-L1 positive and PD-L1 negative. So there's another of the TROP2-directed antibody-drug conjugates called sacituzumab tiromotecan, TMT. SAC-TMT is how this is called here. And this was a trial that was here at ASCO, and this is a large trial. Look, it's 263 patients. It's in a patient population very similar to the ASCENT, triple-negative breast cancer patients treated with a median of 2 prior chemotherapy regimens. The SAC-TMT, this is given 5 mg per kg every 2 weeks versus chemotherapy of physician's choice. And wow, an impressive improvement in PFS in the interim and in the final analysis, and then importantly in overall survival. So again, kind of mimicking what we have seen with sacituzumab in a later line population. And what about the toxicities with SAC-TMT? Well, there is some myelosuppression. As we see with sacituzumab, there's some stomatitis that we see with the dato. Again, we don't know yet whether the prophylactic use of steroid mouth rinse will be helpful there, but it's likely that it will. So again, another agent that is moving rapidly into first-line setting, into the curative setting as well. Very, very effective. The HER3 patritumab, which is an antibody against HER3, with, again, deruxtecan. You don't even have to select for the HER3. It works whether the HER3 is very strong or whether it's not. Here are some data here in pre-treated triple-negative breast cancer patients. And you can see, again, we have another candidate, another target here to go after. And how to sequence these antibodies and mix it up with different payloads is something that we're going to really look for in the future. And speaking of which, this is the TRADE DXD, where 2 antibodies that have DXD, the TDXD and the dato, are sequenced, one versus the other in a randomized fashion, or the dato followed by the DXD, both in HR negative and are HR positive. And then Laura Huppert at the University of UCSF is doing a similar trial, but she is sequencing the TDXD and the sacituzumab. So she's, again, randomizing patients and doing the sequences. That's going to be very, very important data. So we really know what the level of activity is with deruxtecan after deruxtecan, or in this case, a different payload against with the SN38 against topo1 with the sacituzumab. So we'll need a lot of sequencing studies going forward.
That was great. Really, really interesting. We have a number of questions from the audience. I think what we'll do is incorporate them into our next set of questions. So we're going to go on and talk about patients who have endocrine-refractory disease. And we're going to start with ctDNA testing. We'll hear from Neil.
A few other factors brought up from our consulting oncologist regarding the management of metastatic breast cancer, beginning with something we hear about in almost every solid tumor, the potential use of cell-free DNA or MRD-like assays.
I would be interested in learning about monitoring with circulating tumor DNA, in this population of patients. Actually, I would be interested in learning kind of their approaches in monitoring with circulating tumor DNA with both localized breast cancer in terms of adjuvant setting as well as metastatic breast cancer.
So, it's just like the question of the year, I think, outside of ADCs, ctDNA is the next big thing. And at this meeting, we had a whole session on ctDNA, some really interesting presentations, if you want to go back and look at the videos. And I think there's been a lot of discussion. So, what situations would you use tumor-informed ctDNA monitoring? So, it's both localized and metastatic, this question, Hal, for you. So, in early stage disease, do you ever do this? And do you follow ctDNA in the metastatic setting when it's not a clinical trial?
Yeah, it's a great question, and it's such an appealing concept for patients. They really want to understand if there's no evidence at the molecular level of residual cancer, why do I need adjuvant therapy? Or conversely, in the metastatic setting, can you tell me more about the prognosis by understanding what there is at baseline, how much change there is in response to therapy? And my guess is that when we're back here for the ASCO meeting in 2029, we're going to be doing this all the time. But right now, we're not going to be doing it at all because there really aren't that level of evidence. We're getting a lot closer, and this afternoon there were some great presentations on using the ctDNA technology to get there. A couple of caveats, because patients are now coming to us asking for these tests. The first is that there's still a debate as to whether the existing commercial assays like the Signatera assay are sensitive enough to provide reassurance that the tumor, that a negative result is not a false negative result. So that's still work to be done. The second is that it's really hard to know, and especially in the early stage setting, what to do with the result. I got a patient who was adamant that she'd had neoadjuvant chemotherapy for an ER-positive tumor. She really didn't want to take endocrine therapy, and she was adamant that this test, the Signatera test, be ordered because she wanted to decide about using adjuvant endocrine therapy. And the first thing I said is, that's a really bad algorithm. I wouldn't do this, but she persisted, so the test was ordered, and it came back negative. And I said to her, well, I don't know what that means. I mean, it doesn't mean that you shouldn't take endocrine therapy. And similarly, if it had come back positive, it doesn't mean you shouldn't take endocrine therapy. So we're getting there. We will be there, but we're not there yet, in my estimation, for routine either monitoring the metastatic setting or decision trees in early stage.
So before we talk about Dato, a question for you, Giuseppe. So, ctDNA monitoring in the metastatic setting is sometimes used in the community to decide about treatment. So somebody from the audience had a patient who's had HER2 positive, HR negative, ER negative, got 5 years of maintenance with HP, has no response, has a complete response, so nothing shows up. Except for the primary tumor. So the question is, would you do surgery? And second thing is, would you do ctDNA to help you decide when to stop treatment?
No, this is an excellent question because I have some patients on treatment with trastuzumab or trastuzumab pertuzumab maintenance also for 10 years. In a scenario like this, even if clinical practice guidelines do not recommend to do this, so this is the caveat, I would test for ctDNA. And if negative, I would give a drug-free interval in this patient, considering that I can re-challenge eventually in case of reappearance of the disease. This is one of the cases where eventually can be used, but long-term exposure to trastuzumab.
Yeah, it's a really interesting question. Now we have 2 TROP2 ADCs with phase 3 data, where Dato-DXd, of course, isn't approved yet. But Sarah, how would you select between the 2 drugs?
At this point, we don't have comparative data. We don't have good data telling us yet about sequencing and how to best order these, nor about mechanisms of resistance, if it's to the payload, if it's to changes in antigen expression and the target. So I think what we're left with is really tolerability and looking at the patient in front of you and talking to them about the therapeutic index of both of them.
And of course, it depends on the ER status and triple negative and how you're managing this. I think one of the other questions is how we the background is deruxtecan for Dato-DXd and TDXd, say sacituzumab, same mechanism of action, SN38. How would you deal with that question about sequencing? Joyce, I don't know how you would deal with that. There's a patient here that someone sent in who's BRCA positive, 41, HR positive, HER2 low 1+, liver is progressing, had 10 months of TDXD with great tolerance. She's already had all her endocrine therapy, olaparib, capecitabine, and then got TDXD like DB04. So would you give her sacituzumab now? Would you give her chemo first?
So she's getting her olaparib now, when she...
Already done.
She's already finished. We know that one of the mechanisms of resistance to these antibody-drug conjugates can be a mutation in topoisomerase 1. And Aditya shared with us that there's some evidence, I think clinically, that if there's a mutation in topoisomerase 1, that sequencing with another drug that targets topoisomerase 1 in at least some patients will not be effective. So we need a lot more data on that. That's the purpose of the trials that are ongoing. So I generally have not given them back to back. I generally have gone on to other mechanisms of action, but I do end up giving them both eventually in most patients.
And we're all looking for drugs to give, and I think we've all had patients when we can sequence who've responded to one or the other better, whether it's the first or second, even though the first generally works better. So Aditya, tell us a little bit about what we're doing in endocrine-refractory HR-positive metastatic disease.
Perfect. Thank you. So building on the prior presentations and to address some of the questions, I'll review management of endocrine-refractory ER-positive metastatic breast cancer with a focus predominantly on TROP2 ADCs. I'll review the current status, where the field is going, potential challenges and opportunities. So sacituzumab govitecan is a first-in-class TROP2 ADC. The payload is SN38. It has a hydrolyzable linker that can potentially release SN38 in the tumor microenvironment, providing a bystander effect. In terms of rationale in ER-positive metastatic breast cancer, the expression of TROP2 is not that different between triple-negative breast cancer versus ER-positive breast cancer, even HER2-positive breast cancer. So it is an antigen that's expressed in ER-positive setting, and hence the use of TROP2 ADC in this setting. We saw data from TROPiCS-02 trial presented by Dr. Rugo, improvement in progression-free survival as compared to standard chemotherapy for patients who had received at least 2 prior lines of chemotherapy for ER-positive metastatic breast cancer. And impressively, we also saw improvement in overall survival with the use of sacituzumab govitecan, median overall survival of 14.5 months versus about 11 months with standard chemotherapy. And sacituzumab govitecan is a FDA-approved regimen for patients with metastatic ER-positive breast cancer as well. In terms of looking at the correlation between TROP2 status and response to SG versus chemotherapy, we see that there's not a strong correlation between response or median progression-free survival based on TROP2 status, and the benefit with sacituzumab govitecan is maintained even in tumors that have lower expression of TROP2, and hence TROP2 status is not assessed when we are using SG in clinic, at least at this time. How about other drugs? This was briefly mentioned before. Another drug in this setting is datopotamab deruxtecan, which is a TROP2 ADC. 2 points here. First is that the drug, while it targets TROP2, is different from sacituzumab govitecan. First, the actual antibody is different. It is datopotamab. Second, the payload is different. It is deruxtecan, which is exatecan derivative, which is much more potent than SN38. And third is the linker is different as well. This ADC requires internalization of the ADC and release of the payload, and the payload is membrane permeable, which can provide bystander effect. So the mechanism is different from SG, where it has a hydrolyzable linker and sometimes can even release SN38 before attaching to a TROP2 positive cell. Clinically, the other difference is that datopotamab deruxtecan is given every 3 weeks, as opposed to SG, which is given day 1, day 8, every 21 days. In terms of results so far, we've seen results from TROPION-Breast01. It was a trial similar to DESTINY-Breast04 that required at least one prior line of chemotherapy, but it was for all comers, so included HER2 low as well as HER2 IHC 0, showed an improvement in progression-free survival, about 7 months with Dato-DXd versus 5 months with standard chemotherapy. In terms of side effect profile, overall, the incidence of grade 3 or higher AEs were lower with Dato-DXd as compared to standard chemotherapy. If we look at side effects that are common with chemotherapy, like neutropenia, that was much lower with Dato-DXd, incidence of grade 3 or higher neutropenia of 1% versus 31% with standard chemotherapy. But there were other side effects seen with Dato-DXd, including nausea and stomatitis, a side effect that was at much higher frequency with Dato-DXd as compared to standard chemotherapy, and in general is a side effect that's much higher as compared to other TROP2 ADC like sacituzumab govitecan. Ocular events were also seen with Dato-DXd, including dry eye. Overall, the rate of discontinuation was low. There was one patient who had discontinued because of dry eye. In terms of ILD, the drug has a lower DAR. There are 4 deruxtecan molecules attached to datopotamab as opposed to 8 molecules that are attached with trastuzumab. Whether that's the reason that it has a lower ILD, we don't know. But overall, in this study, the rate of ILD was much lower as compared to what we've seen with T-DXd. So all grade ILD 3% and the rate of grade 3 or ILD 1%. In terms of ongoing studies, there are multiple ongoing studies with sacituzumab govitecan as well as datopotamab deruxtecan in the metastatic first-line setting, first-line metastatic ER-positive metastatic breast cancer, ASCENT-07, comparing SG versus TPC, so very similar population to DESTINY-Breast06, but again, it's all comers, so regardless of the HER2 status, whether it's 0, 1+, or 2+. And then you have a number of TROPION trials looking at Dato-DXd, first line, both PD-L1 positive as well as PD-1 negative metastatic TNBC, as well as neoadjuvant therapy, and in patients who have residual disease after neoadjuvant therapy for localized TNBC. Other ADCs, this was mentioned previously, ADCs targeting HER3 as well, like patritumab deruxtecan. And there are a number of other ADCs that are in development or would be coming in the future targeting HER3, different payloads related to HER2 as well. So an important question that we're already facing in clinic is how to sequence ADC after ADC. Conceptually, this could be by understanding mechanisms governing resistance to ADC. And an example of this is from a patient who had received SG, did very, very well, and then had disease progression, expired. We did whole exome sequencing of different lesions. And interestingly, in the same patient, there were 2 different mechanisms of resistance. Some lesions had mutations in TROP2, which is the target of the antibody, and other lesions had mutations in TOP1, which is the target of the payload. So very quickly, in terms of how this could impact sequencing, is that in wild-type conditions, SG binds to TROP2, gets inside the cancer cell, releases SN38. But if you have mutation in TOP1, the same thing would happen. SG would bind to the TROP2 positive cell, release SN38, but the SN38 would not be able to exert its anti-tumor effect because of the TOP1 mutation. On the other hand, if there's a TROP2 mutation, then the ADC does not bind to TROP2 because the TROP2 becomes cytosolic. It's not in the membrane, and thus the antibody cannot bind to TROP2. So this has implications for sequencing. If there's TROP2 mutation, you use a HER2 ADC after TROP2 ADC like T-DXd after SG. In principle, that would still work because you're switching the antibody. On the other hand, if there's mutation in TOP1 and you just use ADCs that have similar payloads, that would not work. But if you use, say, T-DXd, and then after that you use trastuzumab with vedotin or a different payload that targets microtubules, in principle, that could potentially work. But at this time, this is just hypothesis. We still need to understand how frequently these mutations occur, whether TOP1 mutations can cross crest resistance. We have seen some data at AACR that the presence of TOP1 mutations can cause cross resistance, but it's not ready for prime time yet, and we need more understanding related to these mutations and how we can monitor them in clinic. We have seen consistently that in general, the response to ADC2 in patients who get ADC after ADC is lower, but there are still some patients who can benefit from ADC2 after ADC1, and that's why at this time we don't have biomarkers, so at this time we are using ADC after ADC, like SG after TDXT. In the future, if we have biomarkers, that would help us with ADC sequencing. So how to select therapy? At this time, essentially, it's based on the side effect profile. And a point I would make is that ADCs targeting similar antigens can have different toxicity profile. So for example, datopotamab deruxtecan and sacituzumab govitecan both target TROP2, but have a different side effect profile. Similarly, trastuzumab duocarmazine has a different side effect profile as compared to TDM1. We have another example with folate receptor ADC that has eribulin as the payload, which has a different side effect profile as compared to HER2 ADC with an eribulin payload. So it's just not about the antibody, it's the full combination of the antibody, the payload, as well as the linker. So to summarize, it's the full cocktail, the antigens that the antibody targets, the linker, as well as the payload that are important considerations that could impact efficacy toxicity. At this time, SG is approved for metastatic breast cancer of 2 lines of therapy. TDXT is approved for HER2-low metastatic breast cancer after 1 prior line of chemotherapy, but based on DESTINY-Breast06, that could change, and it could potentially be used without 1 prior line of chemotherapy and also in HER2 ultra-low. There are multiple ADCs in development that target different antigens, so in the future, we really need to understand the ADC after ADC sequencing and need to develop biomarkers.
And with that, I want to close. We talked about some really exciting things today. I think the videos were really interesting about the challenges that people face in practice, and then getting the faculty's thoughts on these. And I really want to thank the faculty for taking their time the last night of ASCO, and Neil Love for his excellent organization, and the staff of Research to Practice, as well as our supporters. Thank you so much.